Hi, my name is Jennifer Wallace-Valdes. I'm a physical therapist and I specialize in the treatment of Duchenne and Becker muscular dystrophy. In the past, I've produced many video blogs on physical therapy subjects related to Duchenne and Becker muscular dystrophy. There's one that I haven't done that I'd like to address today. Questions about what to do when a leg fracture occurs come up often, and typically they're at a time of emergency. My hope is that this video gives you some background and some readiness for making decisions and getting yourself or your son back on track if a lower extremity fracture does occur. Fractures happen. Those with Duchenne, especially those who have been on steroids for a while, are at more risk and more prone to suffer a bone fracture. Sometimes they occur with the slightest impact or fall. The most common areas are typically the femur, or the tibia and fibula of the lower leg, or the humerus of the arm or the spine. For the purpose of this blog, I want to focus mostly on the management and the recovery for leg fractures for those who are still ambulatory at the time of the fracture. All of these need special attention, but this particular situation tends to come up a lot and with a lot of urgency. It is important to make sure that we give these individuals the best opportunity to still be able to walk when the fracture heals. First off, when a fracture occurs and the physician has decided whether the fracture will be treated with a cast or surgery, then we can determine what the rehabilitation portion of the plan will be. The overall thought is that downtime after a fracture, whether it be due to pain, fear of falling again, or the medical restrictions, that we limit that downtime to reduce disuse muscle atrophy or further weakening of the muscles from being sedentary or immobile. The diagnosis and management of Duchenne muscular dystrophy articles that were published give us a few tidbits on what to know about the situation. It does say that physical therapists support orthopedics in rapid team management of long bone fractures and provision of associated rehabilitation to maintain ambulation and or supported standing. Also, long bone fracture during the ambulatory stage might need aggressive management to maintain ambulation. Internal or external fixation allows for earlier mobilization compared with casting or splinting. A more conservative approach is recommended for the management of lower limb fractures for those who are non-ambulatory, because the goal is no longer to bear weight. Internal fixation still might be necessary for an unstable fracture, but splinting might be sufficient for bone healing and pain control. So to compare the casting versus surgery, there's pros and cons of each. The pros of casting are that it's non-invasive, there's no surgery required. Many can still do non-weight bearing activities in an environment such as a pool. A lower leg cast might also still be manageable for partial weight bearing or assisted standing or walking. The cons of casting are usually the restrictions are non-weight bearing or significantly partially weight bearing for many weeks, which definitely delays someone getting back on their feet. And a lot of times the cast that's used is heavy and really cumbersome, which makes standing and walking more difficult. If a full leg cast is required for a femur fracture, ambulation really is not very realistic, and also the angles that the knee and the ankle are set at can increase contractures at those joints when the cast is removed. For surgery, the pros are that the fracture is set. It's stable, it's in place, and usually someone can start weight bearing, which means standing or walking, on the first day, which gets you a quicker start to rehab and back on your feet sooner. The cons of surgery, obviously, it's invasive. And the pins that are used, whether internal or external, sometimes they need to be removed. So there could be another procedure, another time of sedation involved. And also to take into account surgical pain and recovery time. The physical therapy plan of care for any of these situations will typically be some of these areas, or most of these areas. We'll continue passive range of motion and active range of motion at all joints that are not affected or somehow otherwise restricted. No walker or other type of assisted device is usually recommended for someone to rehab after a fracture who has Duchenne. It's not usually a very feasible option. And then we try to get you standing as soon as possible within the weight-bearing restrictions that you have. There might be use of something like an anti-gravity treadmill, which you can see here, for partial weight bearing in a controlled environment to ambulate, or partial weight bearing suspension over maybe a treadmill or even over the ground to try to get some weight bearing through the extremities during the rehab portion until you're back on your feet. There's a lot to think about when it comes to Duchenne and especially these special circumstances. I hope this video helps a little. Please also take time to look up fatty embolism syndrome to familiarize yourself with this medical emergency, which is also associated with fractures. At any time, if you or your therapist have questions, please feel free to contact me. My email address is jennifer@duchennetherapynetwork.com. Thank you.